So, everybody for being. We've got a nice crowd, and we've got a wonderful presenter today. Dr. Massy Mutumba, she's an assistant professor in nursing, and she comes from the University of Michigan. And so it's so great to have her here. She's also got her MPH and a PhD in public health. And then, of course, is a nurse for training. So very diverse discipline, really nice. Massy conducts interdisciplinary research on adolescent well-being, mental health, HIV and AIDS prevention, particularly in sub-Saharan Africa, and more recently in southeast Michigan and St. Louis. So really, that's a pretty wide area. Multi-level interventions aimed at improving HIV treatment adherence and reducing stigma, promoting mental health, preventing substance use, and suicide among adolescents for target population she loves teaching. She has a whole lot of publications on HIV. She has PI and MPI on several grants. And she's talked a lot about her, and we talked a lot about her important grant on stigma reduction in Uganda, which someday that's what it's really been answered out. And she's partnered with local organizations in St. Louis even now. So I'm going to turn this over to Massy, and thank you so much for being here.
Thank you so much for the opportunity to have me here. I'm very grateful for the opportunity to share my research. Many of you may be wondering why I'm interested in St. Louis. Well, let me show you that I actually have been establishing a lot of books. I'm happy to have some of my collaborators here. So you have Grace Lomada, I actually have myself and Ryan Lindsay here who I'm working with. And I'm hoping that today I get to share my work and really background and what do I hope to accomplish, not just what I've accomplished, but really in the next 5, 10, 20 years from now. So I've been focusing on a very specific aspect of my research. I work only with adolescents, and I've worked with these cohorts that are really engaging with 16 and while young children. I started out immediately after school, completing my bachelor's of science in nursing, working with young children who are living with HIV. This was just about the time I was graduating in university at that time. So I've had the opportunity to see how does that really treat the epidemic, particularly this epidemic, but also its challenges that are constantly evolving as the adolescents are growing and having a lot of adults and student adults. So I'm really focusing on this school-based approach or school-based community mindset because I think this is the place that really advocates feedback and leverage in terms of improving mental health resilience for the population. Now, with that said, I want to address that a lot of my research is driven just by my clinical background of having treatments about it. But it's also what I see how my challenges. As a continuity as a factor of my health. So why does adolescent mental health matter? We know that across the globe, 1 in 10, 1 in 6 people are adolescents. And when we look at countries such as Uganda, we have the youngest population. Over 50% of our population are young adults. So these are aged 18 years and lower. So again, we have a very big population that also has a big challenge. Adolescence is also this period that is very critical in development of mental health disorders. But it's also the best, in my opinion, really place to, again, intervene here and change the trajectory of risk in this population. So when we think about mental health, we know that 1 in 7 adolescents experiences a mental health disorder, and depression or depressive symptoms are the most prevalent in this population. Mental health problems, again, given my background in HIV, are really both a contributing factor and causes of health problems, including HIV. So when we think about sub-Saharan Africa, again, this was for the longest time a region that people thought that didn't have mental health as a problem, right? But I think the evidence is beginning to bear out. We know that, again, we have a high burden of mental health problems in sub-Saharan Africa, and depressive problems or depressive disorders are really one of the leading causes of loss, again, loss of years of life and health burdens in this population. Most of my research is conducted in the Greater Massacre region of massacre at the moment. So just so Uganda is over here.
Just more on the screen.
Yeah. Oh.
Uganda right over there. But right, it's one of the few countries after the deliveries with the same people that you see in Latin America. Uganda is from the region. And we see really again the issue of HIV has persisted in this region. But correspondingly, we see high rates of medical problems and including increasing exposure in this in the country, especially among the adults and adults. What are some of the underlying risk factors? Again, HIV is a major driver, but we also have other issues that we want to need to control. There's many issues like and poverty, and again, are in this place of so those are some of the key factors that we really need to pay attention and intervene on when we're thinking about the well-being of adolescents in this population, in this context. So my work has really evolved. When I started, I was very much interested in understanding what are the risk and protective factors that underlie adolescent mental health. This was at a time when there was very little in terms of research that had been conducted in mental health, especially among adolescents that are living with HIV. So as you can see from the screen, I started out really looking, for example, at the relationship between psychological distress and adherence. And this was again one out of my experience. When you're in Africa and a number of resource-limited settings, you're everything. So you're not just the nurse, but you're also the cancer, you're also the doctor, everything. So really, it first came to this in the context of really administering I have to be giving medications, then I have to counsel. So then the psychological distress that these adolescents experience, again, immediately and how that affects their parents' treatment. So that's really brought a lot of my research, especially in the research. But as I was thinking about this, other challenges began to come up. How do we really measure this? Because at this point in time, most of the instruments people are using instruments that have been culturally adopted to this setting. And when you think about HIV, actually we found that a lot of other conditions that may create false positive to for depression. Because you're going to ask about fatigue, you may ask about pain. And again, those can be symptoms of mental health. So how do you distinguish that to be able to really accurately diagnose and understand which adolescent is potentially experiencing mental problems and who is really just experiencing side effects of their treatment? So I did a lot of work with psychometrics, really developing again a scale to assess psychological distress that is very specific to adolescents and youth living with HIV. Now, I've continued to do the psychometric evaluations on validation and scale development as I progress in my career because that is indeed that is going on. There is always a need for contextually relevant instruments in population to make sure that what we are measuring and what we plan to intervene on is being population. So when we think about adolescent mental health, where is it being delivered? What are those important contexts? Of course, the health facility as a health worker, I would say, like a first point of contact. But probably not for many people because of how we interpret mental health in our cities. And this is a cultural construct, right? Some conditions may present, may not be necessarily interpreted as mental health. When we think maybe it's our grandparents who are visiting us, someone is experiencing acute psychosis, particularly. That's the grandmother visiting you, right? So the intervention is going to be very different. Maybe you go to a traditional healer to help you cope with the spirits that are visiting, or maybe they just ignore that. It can also be delivered in the community, and this has been extensively demonstrated across multiple countries. So, especially in the context of staff community, thinking about, for example, community health workers, lay healthcare providers that can deliver these interventions, often at a low cost, but also expanding treatment. We also have these interventions, again, empowering parents to be able to support children and reinforce those skills and building resilience in those settings. But the schools, in my opinion, are really important contexts that we need to be having in, and I'll explain that shortly. But first, I really want to address what are those challenges that you're going to experience when you're dealing with adolescent mental health. So my screen has been scrambled a little bit, changing but again, things that I think that are very important is the heterogeneity in terms of age and gender. mental health problems are going to evolve as adolescents grow. The challenges that our young adolescents faces are not the same challenges that adult adolescents face. There may be some continuity, there may be some discontinuities that you have to take that into consideration. We also know that gender is another important dimension. We see, for example, more depressive disorders among female adolescents, but more behavioral disorders among males. So you have to take that into consideration then. You also have a multitude of underlying risk factors. I've already talked about often called mortality. There's also HIV stigma, right? There's the traumas that these adolescents are experiencing. Of course, we can't ignore the genetic component. So if you're addressing mental health problems, what are you going to be targeting? What is the important relevant risk factors for that age group in that context? Access to mental health services. This is not just something that is something you think about in resource-limited settings. It is a global challenge. In all our communities, we have limited access to mental health services, especially for young children and adolescents. It's also the culture, right? I think about my own family. You come to tell my grandmother, that you came to tell my parents that I had a mental health problem, they would be confused that I didn't know. That way to go. But they didn't know language, right? In a lot of our cultures to translate some of these constructs. As an example, I was trying to develop my skill. I was talking to my adolescents and about the question about trying to really translate some kids from the skill was about hacks, and for me, thinking about and I'm like, understand how they need to work. And I was like, wait, they're adolescents, so they're getting into relationships, right? I mean, they're going to be really wild in terms of how they think about these things. But think about being there, administering this questionnaire, and you're just going down on the scale. And all the false positives or negatives you're going to get because I haven't experienced a heartbreak. It's still, very strong. This was really fun. Again, this is something that very few providers that are trained to address, specifically address child and adolescent mental health. For example, in Uganda, we only have about 5 people who are really trained in basic mental health. This is a population of over half of them being teenagers. So how do you address that need? And also fewer evidence-based treatments. When we think about, especially adolescents and children, drugs are mostly directed towards health. How do we address that? So all of these factors really complicate how we address mental health. But for schools, one, many of the children or adolescents spend most of their time in school, right? So it's really a very natural point that we should be intervening. Now, if you're in contexts such as Uganda, where you have a really long school day, and some of these children are getting in as early as 6 in the morning and leaving as late as 6, that is the whole day in school. And they're doing this 5 days a week, 6 days a week sometimes. So if you can't really create very supportive and empowering environments, then you're really going to be more able to address this. And also look at schools and just social adolescents. So there are many risk factors like academic stress that can really be triggering for adolescents, especially if they're already experiencing other challenges that are setting in that negative trajectory for them. And if you add that to the stress that they're experiencing, academic-related stress or bullying or violence that they'll be experiencing within the school settings, whether from teachers or peers, that is really going to accelerate that trajectory. But it's also the opportunities that schools, if we are able to identify an adolescent that is at risk really early, before they really get to this negative trajectory and provide resources, are we able to promote and advance? One of the reasons I love schools is really that you can have multiple approaches. And I do a lot of multi-level research. That you can have programming, for example, at the school level, and you can have programming at the individual level. Right? Personalized, again, when you're being able to do this screening and identification and be able to support adolescents. And it doesn't mean that all of these approaches are exclusive. We can actually have the approaches that are supporting so supporting, for example, creating environments to be literacy with students, among teachers, among staff, and or personally that support students within the schools. or to care-based interventions that creating supportive systems, inclusive policies, or you could really do sort of social emotional learning policies that are much more programs that are very targeted towards the individualized communities to deal with this. Just about the living process, that if we are able to really improve the well-being and experiences we have in the schools, we can improve school satisfaction, academic achievement, but also the health and well-being outcomes that we really care about, that we know that at the end of the day are going to really impact the well-being and the opportunities that this adolescent school experience. Now, these are really good aspirations, but you really have to put this or translate this to the schools right? Now, within the context which I will be talking about it is not very easy, right? You want to do populations, especially when you're between that have high rates of it. And we know that HIV increases the risk for mental health disorders. Layered with that, we also have academic stress. We have a very rigid system. You must pass. You want to pass, that is failure. And we're talking about habits. You want to pass your primary school education, you're going to be in a very poor school, corporate school. That also determines the opportunities and courses that you're going to get. So your trajectory can really be safe right from the onset because of this. There's also very limited access to mental health services. Now, one of the things that we realize, it's not just within the communities that we work with, that the access to mental health services do not exist, but it's also in schools where adolescents are spending most of their time. And mental health stigma is a huge challenge. People don't want to talk about mental health. You appear weak. But when you layer that with challenges that are serious, such as suicide, that eventually is more complicated. So educators will be like, wow, that is too serious. Maybe you don't want to have that conversation. So again, that adds another additional barrier in this context. And also institutional barriers that you have to think about, right? Educators, how much mental health literacy do they have? Or are they going to continue reinforcing these negative perceptions about mental health and stigma? We don't have funding. There are also infrastructure deficits that could again reinforce some of these challenges. You also need parental leave because of the just go for a training school and about it's society to someone's child that can be create a lot of challenges. Policy gaps, how especially as it relates to school mental health. And also the referral processes. So, for example, how does a school deal with a child who's experiencing a mental crisis? Because we've had several instances of suicide happening in school settings. How do you identify a child? How do you refer a child to the caregiver? Do you just take the child's family facility? So that gets really complicated. But again, the opportunity that I already identified, those schools remaining as critical entry points to really begin to introduce these interventions. Of course, with the support of the parents, with the support of the community, because without those, you can't move forward. And I believe that if we are able to do that, you can reduce these barriers. Very vulnerable adolescents who will not be able to access the services outside the school for various reasons. And in fact, financial aspects, it would be that they have to travel very far. Most of our individual services are located at the street level. Or regional level, that requires adult in travel, the financial burdens or the cost of transport can be a really big barrier. Not to mention you get there and the one provider that is supposed to work is you have. So good luck to you. Come back next time. It's also how do we integrate our services in other types of providing, especially HIV. Could that be something that we can do within our setting? A lot of schools offer clinics. If we train nurses to be able to recognize an individual as basic medical aid and that help in that setting, again, there is supervision and referral. And we've been thinking about the cultural studies and management as well. So I do want to move on to the theoretical aspects. What are some of the theories that inform my approach to mental health? And there are many theories that exist, but the one that I find, and I present this here, and mostly just demonstrate that theories. And the one that I find most important, that again is rooted in the aspect of social determinants of health, is the socio-economic ecological model for mental health. It's not very different in terms of the organization of what we know about the socio-ecological model, highlighting the different levels in which an adolescent will be embedded. but also how these different levels are going to interact, either reinforcing or really mitigating some of these risk factors that we're seeing. And we know that the risk factors are going to occur at all levels of this socio-ecological framework. But much as those occur, there are also opportunities for intervention that will exist within each of these frameworks. So interventions that you can develop, either to target the family, the schools, the community, or even at the societal level, really improve mental health and well-being in this population. And if you layer this with the intersectionality theory and the syndemics theory, then you're really beginning to think about these adolescents in a much more holistic approach, right? Understanding that they're experiencing multiple challenges and that these multiple challenges are really going to scale risk. And together, if you're able to do that, I think you're able to develop more sort of nuanced interventions that will be occurring at sort of the multiple levels of our sort of context. So how do I move from this sort of frameworks to practice? And I'm going to use the MSUI study, which is an R1 study that I'm working on as my OPI to address mental health. And the reason I have chosen this within the context of all the things that I do as a physios, finance, and beginners, because it really, I think, is one of the interventions that I'm most excited about because of the potential. So, what's some of the things that we see in school settings? So, I've already addressed academic pressure, the bullying and peer pressure are things that exist. Social isolation, especially for adolescents, body image issues, lack of emotional support, academic achievement, transitions, because again, adolescents are moving from this very protected family environment to living independently, alone, without much any sort of like parent, and they're expected to be able to take on that pressure that themselves. And the substance abuse and misuse that occurs within the society. I do want to highlight one of the biggest challenges that we see for adolescents who are living with HIV in the school setting. So we have various schools. We have private schools and public schools. Now the image here, at the top end with the girls in orange, will really show you what you can see the environment is very clean, it's very, right? This, the dormitories are really arid, right? Very neat. But you also have schools that are not frequentable, right? You can see this addition. So this is really to show that when you're dealing with schools in Uganda, you're going to have, it's not similar. You have very well-resourced schools, you have very poorly resourced schools. The conditions are going to be very different depending on where the adolescent is. And that is very something that variability is something that's very important when you develop intervention because it's not going to be a one-size-fits-all approach. And that is something that again we've highlighted. I will move on to talk about that mental well-being in the context of HIV. What are some of the underlying risk factors? I think HIV stigma has remained really one of the biggest stressors in this context. And it manifests in different ways within the society. So one, the adolescents themselves is already stigmatized and they may self-isolate out of fear of needing to self-preserve, right? They don't want to disclose to others because they fear they're going to be stigmatized, they're going to be discriminated. The caregivers themselves do not disclose this. Again, for fear of discrimination of their child. So they don't keep that silent. Now, about this adolescent who is moving into this recording section, and that no parent around, the school is not aware of their status, and they are going to have to take medications. At 12, this is the fact that they're going to be taking medications without a parent reminding them. And if you have a child, you have to remind them about everything. Just that parent is not aware. This boarding school is also very profound in the sense that it's separate. They are there for 3 months. As a parent, you're not communicating with this child. You see them once a month. And in 6 weeks. Every 6 weeks. That's twice. The school we have to make decisions related to the well-being of the child. If the child is sick, they have to decide. We send the child home or we keep the child in school. That's the school must manage the child. But treatment that they're going to give, even though they're not freely aware of the child's history. Now, because of the lack of privacy, as you saw, those grades are very close together. Now, if you're sneaking around and trying to take medications, because because those bottles are going to shake. Those pills are going to be gathered, and the neighbor is going to ask, what are you doing? Why are you sneaking around and making shaking, bottles? And what is that medication you keep taking every day? Now, much as they're in boarding school, they don't have access to this dormitories all the time. Yeah, wake up in the morning, they go out to class. They're in class all day, the dormitories are locked. If they forget those medications back there, that's it. Then you take the medications until maybe the next day, or they'll try to send you out. So this is going to disrupt their relationships. Now, we realize that with privacy, they're trying to hide with their peers. A lot of them are, once they get into transition into boarding schools, they're falling off their parents. So you're seeing them 3 months later, it's too late. They've been off medication for 3 months. Repeat that pattern twice in a year, our treatment failure. And by making failure. Now, we all know the context of HIV treatment delivery. And on this free treatment that can be for first-line treatments, which most of our adolescents are in second line with treatment failure. They fail on second line, now we try the salvage therapy. Treatments that are very expensive and delivered in the context of research. These are the case in China. Why you really need to focus on these adolescents in this population if you act address the issue of HIV. So how does it impact care? Medication can impact parents, biologic suppression, retention in care. Once they are not adhering, they are also not showing up at that clinic. They are in charge. Healthcare providers, we are really, really harsh because we don't understand why. After I cancelled you, why you still are not taking your medication? You forget to eat another. It really is very logical, but it doesn't really. It's not a long one. It's a non-disclosure. Yeah. So this study in Slovakia, aim for multi-level, really targets adolescents who are living with HIV between the ages of 10 to 17. They have to be enrolled in care, but attending a school with a boarding school. We have a lot of schools. Some will be completely boarding, some will be day and boarding combination. So, but any school with a boarding section is eligible because we want to make sure that when we intervene on the school, and we are affecting not just the adolescents that is in our study, all adolescents who live with HIV in school will benefit from it. We have 840 adolescents recruited from 42 clinics. In terms of schools, because it's not the same up here, usually the expectation is you go to the neighborhood school. That is not exactly what happens in the country. You go to the school that you like and afford. So that means that when we recruit our adolescents at the clinic level, we end up with adolescents that are in our setting. So right now we have 118 schools that are involved in this study, which are in our intervention plan. And what does the design look like? So adolescents are randomized to one of 3 treatment options. The standard of care is standard of care, which I'm going to explain, standard of care plus family-based economic empowerment, and then standard of care for family-based economic empowerment plus the school-based stigma reduction. So those are the 3 ones that I'm going to describe. So what does that sort of standard of care individualized approach look like? We have a tool-based curriculum that tackles HIV treatment and disease and overcoming barriers to HIV treatment and behavioral stigma. So really addressing those issues that they're experiencing. And then go over this with our community health worker, social counselor, and their caregiver, again, reinforcing this information within their schools. At the family level, what they have is a component that has been developed here at WashU and very elaborately tested, the family economic empowerment. So this includes, again, family. They go through 12 sessions, which are based on strengthening the relationship between the adolescent and their caregiver. Now, in addition to that, we include a stigma reduction component, recognizing that adolescents experience stigma in their homes too. It's not just schools. Even within their homes, because many orphans in schools where people are not living with HIV, so they have the same, again, stigmatizing beliefs and misconception of HIV. So that addresses that, plus the family economic empowerment, which includes matched funds that are supposed to help them address challenges related to addressing multiple barriers, transportation, food insecurity, educational expenses, supporting nutrition in family kind of really developing or acquiring assets that we know are really important for these adolescents and their families. Now, the third component, which is the school-based component, targets educators. So when we talk about educators, what we are looking at is school administrators, teachers, school nurses. We also have people who run these schools because the dormitories where the adolescents stay, so we put them audience or parents. So we target all those people that interact with the adolescent because whoever the adolescent may interact with and they have that negative experience, it's going to stay with them. So you want to make sure that all the people that are interacting with this are supported. It's delivered using 2 days of trainers or trainers model. 100 schools. So we train one educator and support that person to go back to their school to deliver education. And this is very important because the schools are very different cultures. They have very different cultures in terms of how they work. So you can't dictate what type of education school to do. They have to think, as part of the training, they think about what does my school look like? What other challenges are experiencing in the school? And what would be the most ideal intervention that exists? This is just sort of like a curriculum that they go through. And the group has quite a lot of not just building knowledge about HIV, displaying myths related to HIV and stigma, that really feel the stigma. What does it feel like for an adolescent in this setting? What are the challenges that they will face, for example, trying to adhere to management? How mature are you, for example, limitations, stigmatizing? Some examples could be, for example, here, the nurse is being very supportive, calling out to this adolescent to come and take the medication, which happens. These are based out of what adolescents share as their experiences within the school setting. The nurse just comes, she's like, oh, you come and take your medication, but they're calling out, you out of the classroom, and everyone's like, what medications are you taking? That you have to explain that to your peers. It's things like, the teacher refusing sometimes to call out the student. Collective punishment is very common in our school settings, right? And the teacher may be like, oh, you have a problem, so you won't participate in this punishment. And now the adolescent is feeling left out. Not that, you want to be punished, but as an adolescent, you really, really want to be punished. Right? Other things are like, we set up nutritional programs, special meals for adolescents who have diseases. But again, that is stigmatizing the adolescents. So how do you address this? What sort of policies do you develop or programs that can support them and not reinforce? So our expected outcomes is that when we intervene at the school setting, we're going to see this change in treatment outcomes for our adolescents that we're going to measure at the age. Now, that is important because we are not going to schools and telling them, we are recruiting you because you have an identity in the school, is in our study. It's a very general, we are training providers about, schools about HIV. But then disclosing that they have adolescents or which adolescents have that at this time. And so that's why we can't measure any outcomes. We can't measure that. We also care about other secondary outcomes, right? Academic improvement, in addition to student health and treatment adherence. So, moving ahead, what are some of the things that I'm going to do? I just wanted to highlight some of the work that again intersects with this work on treatment substance use, especially as adolescents grow older. And this is again a consequence of substance use HIV, so coping with stress with HIV that drives adolescents to substance use, it's poverty. So there have been studies again that are related to adolescents and comorbid conditions that are commonly in education, and making sure that we can provide the necessary tools and programs to address that in the setting. It's also looking at other traumas that are co-occurring. We know that, for example, sexual violence is a big challenge. And it could be one of the reasons why an adolescent will be infected with HIV, but also that adolescents who are living with HIV report high levels of sexual violence. So when you're thinking about that in terms of preventing transmission of HIV, it's important that we address this. But again, this is something that is probably neglected in us service provision and it's addressed. And that is what this grant and its vision have done. And beyond depression, which is a very common occurrence, is also thinking about things like suicide. Again, another emerging epidemic that is often occurring in adolescents. And here I want to use this opportunity to highlight what kind of limits that I think is very important to think about again improving the mental well-being of adolescents, especially in a school setting. So this is what I'm doing with my and we are doing it with community-based planning. So the behavioral health response, HR, is implementing the National Suicide Screening Line in Missouri, and asking that school-based screens and referrals to HR. So when you think about creating that integrated continuum of care, you don't just focus on schools, but also making sure that the community resources are linked, depending on where adolescents are, there's a seamless referral pathway. It's important that you work with the organization for this. And this is about your work that we are interested in. One of the things that I really excites me about this one is thinking about the culture and also the development aspects of suicide screening. We know that we ask questions and we think everyone understands our question, like, I want to be yourself. Well, I explained myself wasn't really too much. Explaining self-harm behaviors also could be an indicator of suicide, or is it unconscious suicide attempt? And for younger adolescents, really young adolescents, because we know suicide ideation as early as 6. How do you start, or how do you ask those questions? But most importantly, how do you engage caregivers? Parents, because these are very critical partners. And that starts with how you communicate with feedback. I'm a child, so I'm very sure that if someone came and told me something about my child, first of all, I'm going to be like, is it true? Why did you screen the child? Who gave you permission to screen the child? I mean, like, there's going to be a lot of questions I'm asking about my child, right? And those can be barriers. But we also have to think about what else is being important. And how does that affect the casket? Here, is it going to be enhancing that casket, or is it going to be casket? So that communication, and having been a provider, and I'm like, it can be very abrupt, you're like, oh yeah, child tried to commit suicide, right? That's what I do here, and we really express that in very different ways that maybe will help or not will help experience. So that is what we are doing. But correspondingly, also thinking about how would that really help, for example, in a human city. We are aware that our providers, for example, are not being trained adequately or even at all. That is something that is missing, even the mental health providers, right? So you don't have just a limitation on the number of people, and it's super being trained. And again, same questions: how do you involve and have each other credit card? And we really want to build on what we've seen as best as supporting families within this care. Using multiple family groups, intervention approaches, and then really using that in combination with food, but in an evidence-based program for suicide that have been very effective. So that is again another body of work that I'm thinking about and working on. And then think about other things that are very helpful, motivating physical activity and sports, especially that we know are very effective in reducing suicide among adolescents. Simple things that can be again impacted at school level. Sports, physical activity. We reduce within our schools, funding for sports and physical activity is reducing. So that could be some things that we can do in terms of policy level, advocacy level, but also thinking about how do we deliver this program and maybe removing the value if the schools are not willing to do that to communities, and also addressing other barriers. If you have to take your child every day to sports, or even once a week, and you need 2 sports, because for the benefits, to accrue the benefit, you need at least 2 sports. But we know that can be very burdensome. Time, expense, those things are very expensive. So thinking about how do we bridge those barriers, especially for vulnerable communities, and that are going to be experiencing high levels of poverty. So with that, I will invite you. Thank you.
Wonderful presentation. Due disclosures, I do work in cognitive resilience, so I'm very biased towards work that does resilience is being beneficial. And the second is, my question is a little bit colored by some of the work I've done in Berkai. I haven't been to nonprofit, so I don't know how relevant it'll be. But if your interventions are successful, especially these school-based interventions, and you build up a resilient adolescent, that in itself is a success, of course, but one of the things that I often run into and think about resilience is some of Sherman James' work on John Henryism and this idea that even if you build individual resilience, if your environment is going to push down on you and beat you time and time again, they're adding stress and increasing your risk for other things. So in the context that I worked in for Kai, for boys in particular, you might be HIV positive, you get some of this work, you build a lot of this resilience, and then one of the best paying jobs in the area is to go be a fisherman on Lake Victoria. And not only is that highly risky, you now left this very safe environment that you built up that had resources and educators. So like thinking about that transition from adolescence to young adulthood and just the high risk of it, I know that's a little bit beyond the scope of your current work, but have you looked a little bit into what might support that transition, given that there's this, you're building such a great environment in the school setting that is kind of lost immediately once they leave school. And some of this, of course, your work with family in particular may be really a good point of discussion.
And actually, what you talked about is something that we see in our work and substances. I'm a mother as well. That those social conditions are very critical challenges for adolescents. And it's not just really in terms of living in the communities, but it's maintaining the fish care. Once they go, because when the fish migrate, fish, and it will be 6 months before they can come back. But thinking about, again, this sort of involves this aspect of the different jobs, right? How should we be thinking about and ensure that it's still in communities that are going to suffer? That requires, again, this sort of multi-level interventions, thinking about community involvement, also thinking about adolescents, not having to get jobs that require them, where they have very little control over their lives, but have to think about this. So, requiring them to pursue opportunities that are going to be able to assist needs. When they have a bit more control, they can show us things, right? That would be something that again gives the structure. We have very little control over patients, and that is one of the things that we share about it. So it requires a lot of thinking, it requires a lot of planning, but I feel like when you build these multi-level interventions, but also about the example, these communities for patient communities, the only job you have is the patient. So what should we be thinking about diversity? That is sort of like all other aspects of that. That's why we think about disciplinary research projects, right? Thinking about communities. Because we just don't focus on one aspect.
Thank you so much for a really interesting presentation. I'm curious to hear how in these interventions do you measure stigma reduction at an organizational level? How do you know if a school's environment is less stigma?
So let me look at our research, which we use in the adolescents of their experiences within the schools. So we did a baseline assessment to have their sentiments in terms of how they perceive the schools. So you're measuring over time how is this shifting. Of course, knowing that organizations, you don't shift things immediately. We're expecting that students are going to see and immediately posting. And we're also assessing teachers. We have reports from some leadership and also taking reports from teachers. Both qualitative and quantitative, looking at their own attitudes, especially around stigma. So looking at qualitative aspects.
Like, what are some sample items? I'm just curious to know how you measure that.
So a sample item on the scale is really my school is supportive. Right? I feel safe in my school. My peers do not discriminate me because I have. So the scales are really developed to target those together that education to really show wow this classroom.
Thank you. That was fabulous. I have two questions for you. So let's say hypothetically you were to get a gigantic grant that would allow you to think in terms of the social ecological model, but also the syndemic model. So if we're thinking about that theory, I'm curious in your view, what would be the sort of mini epidemics? Would it be substance use? Would it be violence? Would it be, I know that you focused on HIV, but what would be those that you would target? And then the second question is about, do you work with the Ministry of Education? Does the, sort of working with private schools versus public schools bode well for policy impact? Just curious about that.
Great question. So what would you have? And if I had one, thinking about really those key determinants of health. Thinking about poverty. The reason, for example, I choose poverty, right, is because I believe it's really one of the risk factors for everything. It's not just mental health. But you know, for example, girls from poor families are more than violence. So if you can address that, first of all, really setting the ground by that would be very helpful. Then once you've done that, reinforce mental health. And this is starting from early childhood. We don't wait until they are adolescents and then they are really beginning to go off on a very different career. Start early. Our money, we should even move lower. I'm not going to wait for them. I'm going to start early. You know, we have nursery schools. Kids go to school as early as 3. Very formal education in Ghana for years. So start early. And I think that really begins to set. You know, if you build these schools that are very supportive, teachers understand and know how to promote mental health, especially in this population, in these communities that are very vulnerable. Our communities are very mixed. You're going to have the refugees, migrant populations. You're going to have children not coming from very different backgrounds. So if you can build those that support mental health, because we know, for example, mental health is going to be a very important factor in such situations. Address mental health. All the groups and it is so hard. And if they want to solve the problems, again, that is also going to be depression. I mean, like social rights. So I will go there. And in terms of your involvement, in terms of the involvement with this education, this one of our plans is this in terms of right from the onset, EVG. You know that we are such a what is it and we can't do that without that. And it's also recognizing that even poor families are going to take their children. And they'll sell the chicken because they want everyone wants their child. So you can't say I'm only going to focus on private school, I'm only going to so it seems that being able to understand that the resources are being given. But you can also find a private school that is really terrible, worse than a government school. Because we have the traditional schools, we have schools that is church founded, we have schools, I mean, even have fake international schools. So everything exists. Regulations. So that's the institute.
So, really nice presentation. Really enjoyed it, and I'm hoping you get the big grant that Laura was talking about. Don't we all? But a question about the intervention, because I really think it's interesting working with schools, and they're really great resource to do that. You have all of those schools, and we all know when you do intervention, some schools do better than other schools. Teachers leave. I would assume that happens. Teachers leave, things change. What kinds of strategies do you envision now or even moving forward to make sure the quality of the intervention stays intact? And or how did you deal with that currently, or how are you dealing with that currently in your intervention? I realize you've got a randomized design, so maybe you're letting things happen as they happen, but moving forward even, because that seems like this would be a great intervention, but some schools are going to do it much different than other schools, and sometimes teachers just won't do it. So how do you handle that?
It's basically that every school is so the emphasis is on documentation. Every school identifies issues and decides their intervention. And so that documentation is what helps you understand what the community is. But also you have to take into consideration what sort of resources are going to exist within the schools. Now, teachers are going to have, that is the reality. You're never going to have that process, but you need to build that critical mass within the schools, which is why we carry it out. So, yeah, maybe it's running here, but next year someone is still there to sort of carry on and institutionalize and continue institutionalizing those key which they themselves have developed. So in essence, it becomes like this really life evidence because you're not prescribing to schools what they should do. You cannot do that. You can encourage cross-school learning, which is why we bring them together. We have booster sessions, they share the experiences. This is what I've done, this is what has been successful. Others will find challenges because, like, again, in the real world, some educators may not be very enthusiastic. But again, that is part of the evidence that we're building, understanding in the next iteration what moves them, what holds back schools, and what sort of supports are necessary to really make sure that we are implementing, continue to implement this.
And a second question, do the children, if they go home, then do they go back to that school again, or are they also moving around school?
So we've had changes.
They go back to that one again, okay.
That is secondary school. Secondary school in Uganda is 6 years. So it's primary school, so they're still within that.